4,
We
3, 2, 1. So we are live.
Good evening, friends. We thank you all for logging in to this third version of the virtual CMC Thyroid Masterclass. It's our privilege to present the work we do here at Velo and the strengths we like to portray through this webinar is primarily the teamwork between various departments and specialties involved in thyroid work. At the outset, I must thank the departments of endocrinology, nuclear medicine, endocrine surgery, which is my own specialty, along with radiology and radiation oncology, as we present the teamwork which we do here at CMC. The idea of making this masterclass or telecasting this masterclass is primarily to show what we actually do with the patients we are managing. And I believe the best tool for learning is our own patients. And the cases presented in our panel are patients who we have managed and have taken it to completion. And the idea is to actually present not only the science of learning, but it's also the teamwork and the philosophy of working together. And together I have with me on the moderating panel is my illustrious senior colleague, Dr. Nihal Thomas, who is from the Department of Endocrinology. And I would hand it over to him to moderate the first session, which is a talk by our colleague, which is Dr. Nitin Kapoor, and he would be presenting on pregnancy and thyroid diseases. Over to you, Dr. Nihal.
Thank you, Deepak, and good evening to all of you. We go right down to the academic part of our session, and I would like to introduce the first speaker of the evening. This is Professor Nitin Kapoor. Professor Nitin Kapoor is a professor in our Department of Endocrinology at Christian Medical College, Velo. He's an upcoming star in the area of endocrinology on a national and international front. Nitin has done his DM in CMC Velo and his PhD subsequently at the University of Melbourne. He has a number of publications to his credit. He has a particularly passionate focus on the area of obesity, which is largely translational from epidemiological work as well as genetic work. Nitin will be talking to us today, particularly about the area of pregnancy and thyroid disease. So Nitin, over to you without much ado.
Thank you very much, sir, for that introduction. And right at the onset, I'd also like to thank Professor Deepak Abraham for having me here today. And over the next 15 to 20 minutes, I shall take you through this topic of thyroid disorders in pregnancy. And though it's a very vast topic, what I would do is I would present to you this topic in a case-based discussion manner. I would present to you today 3 cases that we've managed here. And these are 3 patients who come in different stages of pregnancy with different thyroid disorders. And what I would do in the next 20 minutes is try and address the important questions that cross a treating physician's mind, or maybe even I'll say even an obstetrician's mind when they manage these patients. I'm going to present to you 3 patients. The first patient is going to be the story of a lady who was referred by the obstetrician for management of hypothyroidism. I'll get back to the details of this case in a while. The second patient that I will present is a patient who was noticed to have a thyroid swelling somewhere in the middle of her 2nd trimester. She was all scared after reading all about thyroid cancer on Google, and she wanted an urgent appointment. We'll talk about this patient second. And the third patient that we'll talk about today is a patient who was referred for evaluation with classical symptoms of thyrotoxicosis. What we're going to do is for each of these patients, we'll try and address the important questions that cross a physician's mind, that cross the discussion with the patient when we manage these patients. And let's start with our first patient of hypothyroidism, and let's look at the case in a little more detail than what I told. So this patient was referred to us by the obstetrician. This is the story of a 34-year-old lady. She's in her 1st trimester. She's referred for evaluation of high TSH. She's known to have primary hypothyroidism for the past 2 years. She's been on thyroxine, and as we see, her values of TSH have been fairly well controlled all throughout. But it is only now that during her pregnancy, she's got a high TSH. She has no family history of hypothyroidism. There are no clinical signs and symptoms of hypothyroidism. There's no goiter. But at this point, the obstetrician is concerned, the patient is concerned because they have a TSH value which is out of range, quite high, I would say 9.5 micro international units per ml. The T4 is a little on the higher side, and we'll discuss about this case. And I think the first and the most important question that we need to address here is, before we talk of anything, is how do we interpret thyroid function tests during pregnancy? And I think before that, let's talk of a little bit of what we've learned in physiology. And what we've learned in physiology is that the thyroid hormone production is a very tightly regulated, very well-regulated hormonal axis, where we have the hypothalamus producing the TRH, which stimulates the pituitary gland to produce TSH, which in turn produces hormones like T4 and T3, which have a very good negative feedback both on the hypothalamus and the TSH. Well, this is normal physiology, but what goes wrong in thyroid disorders primarily affecting the thyroid, disorders like primary hypothyroidism, where the thyroid gland isn't really functioning that well, and therefore the T4 would be reduced. I would say the most common cause for this would be autoimmune destruction of the thyroid. And when the T4 is reduced, the feedback mechanism gets into action, leads on to elevated TSH, what we measure clinically, as well as TRH. Whereas in patients with primary hyperthyroidism, wherein the thyroid gland is hyperfunctional, it produces a lot more T4 than what is required, which in turn goes back and suppresses the TSH and the TRH. Well, we are concentrating here today on primary thyroid disorders. We did cover secondary thyroid disorders in the last edition of our masterclass. And the most important point that I would like to leave on this slide is that if it was one test that we do in thyroid disorders in clinical practice, which will tell us which way our patient is, whether the patient is hypo or hyper, it is TSH. Not only because TSH goes really well with the assessment of these disorders, but even the assays for TSH are fairly very good and robust. So what goes wrong in pregnancy? What changes in pregnancy? And I think the first and the most important thing that we all have learned in physiology is that during the first trimester of pregnancy, or as soon as pregnancy is confirmed, the HCG hormone from the placenta starts to increase. This happens immediately. It peaks at around 16 weeks of pregnancy. And this HCG has a very similar structure, common alpha subunit to TSH, so much so that it can act on the TSH receptor and kind of fool the TSH or the TSH receptor or the thyroid gland to produce more T4. So this HCG, which is not TSH, but something that resembles TSH in its structure, tends to act at the TSH receptor and thereby produces much more T4 than what is required. In endocrinology, we call it as the specificity spillover effect of one hormone over to another receptor. Now, when the T4 starts to go up, its action happens to the hypothalamus, where obviously because of the feedback mechanism, the TSH drops. Not only this, there's also more estrogen playing a role there, which acts on the liver and produces more thyroid binding globulin, which in turn increases the total T4 concentration. Not only this, there are several other dynamics with respect to the iodine demand, both for the fetus and the mother, increased iodine clearance, the GFR that goes up. And all said and done, cutting a long story short, in pregnancy, the TSH is much lower than what is actually in a non-pregnant state, and the T4 is much higher. Just a couple of points that I'd like to highlight here are that whenever we do have a higher dose of HCG, and for the obstetricians who are logged in to listen to us here today, yes, when you have twin pregnancies, when you have high HCG, you would get a much more suppressed TSH. So in normal terms, if I say in the first trimester, about 15% of normal pregnancies would have a suppressed TSH, but if there's a twin pregnancy, it would be much more. The other important point that I'd like to highlight here, and though we say, yes, the total T4 goes up during pregnancy, it is important to know that even though we say it's 1.5 times the upper limit of normal, that peak usually happens only by 16 weeks of gestation. And in the first 2 weeks of gestation, the T4 may not be that high, and it starts to increase after 7 weeks, about 5% every week. And so we need to keep that in mind, and we don't jump on and say the T4 is not elevated if it's before 16 weeks. So these two important points, the thyroid guidelines globally, the ATA, as well as the Indian guidelines do tell us about the importance of trimester-wise cutoff that we should use in clinical practice. These cutoffs were much lower in 2014. The 2017 guidelines have raised the TSH bar to 4. However, there is some kind of importance of ethnicity that is to play, and we still don't have robust Indian data with respect to this. And what is proposed for the Indian setting today is still not 4, probably 3, a TSH of 3 would be appropriate in the first trimester, and maybe 3.5 in the second and third trimester. This is only consensus based. We still need to have our own data to tell what is the best for our patients. Talking about T4, as I mentioned, yes, by 16 weeks, the T4 should reach about 1.5 times the upper limit of normal. In pregnancy, we would check the thyroid functions every 4 to 8 weeks, depending on how frequently the patient can come. So that addresses my first question that I need to know before I talk to a patient who's pregnant. We need to know how we interpret the thyroid function tests. But let's take a step backward. And this is something that is very common in clinical practice, wherein patients are referred to the physician before planning pregnancy, and especially in the era of artificial reproductive techniques, where there's so many IVFs that happen. The IVF or the reproductive medicine physician wants a good result, don't want the thyroid to play the bad role in their outcomes. The patient who's spending a lot of money for IVF would also want a TSH and a good green signal from the endocrinologist or the physician that the TSH is normal. So what is an optimal TSH when a patient is being planned for pregnancy through an artificial reproductive technique? Well, what is well known in literature is that we know that subclinical hypothyroidism, or TSH, as it increases, does have a dose-related action on the ART outcomes. We know that TSH concentrations can be very variable during pregnancy. And what is recommended today is that people who are planning pregnancy through artificial reproductive techniques should ideally have a TSH of less than 2.5. Now, this is based on the small randomized controlled trial, which was published in Endocrine Practice almost a decade ago, where they randomized 2 groups of people, wherein they gave thyroxine to people with subclinical hypothyroidism to maintain a TSH of less than 2.5, and another group where they maintained a TSH which was more than 2.5. And that's where this magic number of 2.5 is entered the guidelines. And this is only for those who are going for artificial reproductive techniques. Well, somebody for normal pregnancy, we still don't know the answer, and probably a normal range TSH should suffice. Addressing the third question, and that is another commonly asked question in clinical practice: when do we ask for thyroid antibodies during pregnancy? What is their role and how we talk about it? And yes, when you look at literature, both anti-TPO and anti-TG antibodies are present in about 2 to 17% of pregnant women. And though the ATA clearly recommends that thyroid antibodies should be checked in pregnant women when the TSH is 2.5, sometimes in clinical practice, especially in the Indian setting, this cannot be a very cost-effective measure. But what is very, very clear in literature is that when we follow these patients who have thyroid antibody positive status, their TSH tends to increase much more than those who are antibody negative or those who are thyroxine on thyroxine. Not only this, what is also shown in different studies is that when you look at the odds of having a miscarriage or a preterm birth, we see the odds is as high as 3.9. That means women who have a thyroid antibody positive status have almost a 4 times higher risk of having a miscarriage, or maybe a 2 times in this study, or a preterm delivery of a higher risk of 2. So again, cutting a long story short, what is recommended today is that when women have TPO antibody positive status, and I will allude to this in more detail in the next question, the overall recommendation is very weak. But looking at the risk and benefit ratio, if there is a patient who has TPO antibody positive status, they do suggest to start thyroxine therapy in a very mild dose. Again, monitoring is required. And this takes me to the fourth and the most important question in clinical practice: how do we manage subclinical hypothyroidism in clinical practice. We know subclinical hypothyroidism is said to be when in pregnancy states, and if we take the TSH cutoff of 4 as recommended by the current ATA, and if the T4 are normal and the TSH is less than 10, we would say that patient has subclinical hypothyroidism. In Indian settings, and in this paper, which was published in December 2020, a significant proportion of people in India, pregnant women, have subclinical hypothyroidism, almost responsible for about 50% of all thyroid disorders seen in pregnancy. And though our awareness of treating this has increased over years, over this 13-year cohort from Finland, we've seen that it's increased almost 5 times. What is essentially recommended is that thyroxine therapy should be given to all women with subclinical hypothyroidism if definitely they have a TSH of more than 10, even if they are TPO negative. Well, it should also be given to all women who have a TSH of 4 to 10, and if they are antibody positive. And it may be considered in those who are TPO negative and have a normal TSH less than T4. I know it sounds confusing, so I've put it simply on the slide, easy to remember. We would treat all pregnant women who have a subclinical hypothyroidism, and if the TSH is more than 10, we definitely treat. We definitely treat all women who have a TSH between 4 to 10 and are antibody positive. The evidence is weak, but we do consider treating, looking at the risk and the benefit ratio in TPO negative women who have a TSH between 4 to 10 and TSH between 2.5 to 4 if there is a TPO positive status. What the current ATA at this point recommends is no treatment if they are TPO negative and the TSH is between 2.5 to 4. So in simple words, yes, we would treat most women, whether TPO positive or negative, if their TSH is more than 2.5. The utility of actually doing the thyroid peroxidase antibody test is mainly in this gray area, which may tell us how robust our treatment is going to be. But overall, we would tend to overtreat than undertreat. So with this, let's get back to the case where we started. This is the 34-year-old lady on thyroxine 75, well-controlled TSH all throughout, until the day she came back first time in pregnancy. Her TSH is 9.5, and the key, definitely she warrants treatment. I wouldn't do a thyroid antibody in her, as I mentioned to you in the last slide. TSH is almost approaching 10. She would require an increase in her dose. The key learning points from this patient include that, yes, TSH and high T4, lower TSH and high T4 are the usual norm in pregnancy. TSH is indeed the most reliable test that we do in pregnancy, and free T4 isn't that great given the assay limitations. Pre-artificial reproductive techniques, the recommended TSH would be anything less than 2.5, and lower thresholds are required in those who are TPO antibody positive. So with this, I move on to the second case, and this is the story of a 26-year-old lady. She's currently in her second trimester, and it is one fine day that somebody has noticed that her right side of the neck looks more bulkier than the left side. She's noticed this since 2 months, and of late she's Googled everything about thyroid cancer, thinking this is nothing else but thyroid cancer. Extremely stressed out, wanted an urgent appointment. There's really no difficulty in pain, difficulty in swallowing, no pain, tenderness, or no clinical symptoms of hyper or hypothyroidism. And this is the reason why she's been referred to us. Again, looking at a couple of questions that cross through the treating physician's mind. And the first important thing that we really need to know is how really common is thyroid cancer in pregnancy. And this is really important to tell our patients who would be so worried and thinking that every thyroid nodule that is approached as cancerous. That's not true. We know that the prevalence of thyroid nodules can be quite high. This would obviously depend on the way these studies have been conducted. If you have an ultrasound-based study, it would be much more. It increases with the duration of pregnancy, increases with parity, but the important message that we have to learn is that the prevalence of thyroid cancer, and this is data from the California Cancer Registry, follow-up 9 years, looking at so many patients, over 48 lakhs patients, the prevalence of thyroid cancer in pregnancy is extremely low. Even though thyroid nodules may be seen in about 3 to 30%, the cancer prevalence is only 14.4 out of 100,000 patients. So it is extremely low, and this we are talking of papillary cancer, which is indeed the most common cancer. So the first thing to calm down the patient is that, thyroid cancer is not that common as thyroid nodules. Next, once we have this patient in our clinic, we need to clinically evaluate. We need to see the biochemical and the radiological tests that we need to do. And probably the two most important things on clinical history that I would like to flag in patients with pregnancy is that we need to find out about family history. These patients are often young, they are in their reproductive age group. And if they've come with a thyroid nodule, it's important for us as clinicians to find out about the family history of similar nodules, about the family history of associated syndromes, because this may be an opportunity to pick that up, not only for the patient, but even for the family members. Another common reason of developing thyroid malignancy, and that is something that we need to find out, especially in childhood cancers where they may have received kind of a whole body radiation or head neck radiation. Yes, we do ask for an ultrasound of the neck, and the interpretation is pretty much similar to what is there in the non-pregnant state. We as treating physicians should look for simple signs or simple messages on the report, whether it is a hypoechoic nodule, whether it's an irregular margin, whether there is microcalcification that is present, or whether the nodule is more tall than large, or if it is very vascular. Now, these 5 things that I mentioned would tell us that there is a higher risk of malignancy there. And if these are not there, then it is a low risk. We can do the thyroid scoring. This is very similar to the non-pregnant state. Well, other tests that we talk about, serum calcitonin is not recommended unless you have a strong suspicion of dealing with MTC. It's not routinely recommended. Thyroid function tests are broadly normal in patients with pregnancy. I think the only important difference in the non-pregnant and the pregnant state is that in non-pregnant state, when the TSH is suppressed, we often recommend doing a thyroid uptake study, which obviously cannot be done during pregnancy. And the TSH itself can be suppressed normally in pregnancy. As I mentioned, about 15% of normal pregnant women would have their TSH suppressed in the first trimester. Yes, FNAC is recommended in people who have a non-suppressed TSH. Talking about management of thyroid cancer during pregnancy, yes, overall, in simple terms, the simple rule is wait and watch. And even if we have an FNA-proven papillary thyroid cancer, we would monitor that patient. If it's been diagnosed in the first trimester, we would monitor that patient and look for substantial growth. What is substantial growth? The ATA clearly defines it. Any significant growth which is more than 50% in volume or 20% in diameter, at least in 2 dimensions. And if these 2 are present, yes, the patient may warrant surgery. And this would be best done in the second trimester. But however, in most cases, if this is not the case, we can wait till the delivery. And if the disease remains stable or has been diagnosed in the second half of pregnancy, as is the case for our patient, if it was a PTC, the surgery can be deferred until delivery. Does this have any impact overall? Yes, what I mentioned for PTC is clear. We wait and watch, but may not be for obvious reasons, the anaplastic cancer or those with medullary carcinoma, where we should not lose time. And there is a discussion on MTC later on in the session today. But overall, in these cases, yes, we would like to recommend surgery. And if we talk of the indeterminate nodules, overall, again, unless they show a clinically aggressive behavior, we are not keen to operate these as well. This coming on to the last question for this patient, and this is another clinically relevant question. What should be the TSH goals in patients with PTC during pregnancy? Yes, we know that in non-pregnant states, we are often paranoid to keep the TSH suppressed, depending on the stage of cancer that the patient had. And given that even in normal pregnancy, the TSH remains suppressed for a significant number of people, there is absolutely no problem with respect to TSH suppression during pregnancy. It can be safely maintained, and we need to monitor this more frequently. And especially if we are changing treatment, it needs to be monitored every 4 weeks. Right. So with this, for this particular patient who came in a second trimester, her ultrasound was actually not showing much significant, any significant features of malignancy. It was a TIRADS2 lesion. The FNAC was not really predictive. It was an inadequate sample, but given this, we followed her up. There was no increase in size during the rest of her pregnancy, and this patient had a probable benign nodule and did not warrant surgery. So the key learning points from this patient that we learned are that thyroid nodules are common, but malignancies are not. When we have young patients, and these are patients in reproductive age group, it's important to find out about syndromic associations, both within the patient and the family members. Overall, the rule of thumb in PTC is wait and watch unless there is significant growth. However, in MTCs and anaplastic etiologies, we would tend to operate. And with this, I move on to the third and the last patient that I have to discuss today. And this is the story of a 32-year-old lady. She's presented in her first trimester, and she has classic symptoms of thyrotoxicosis, weight loss, palpitations, and prominence of eyes. Now, as we see her eyes, there isn't really much activity. There isn't really much redness, or the patient did not complain of any pain. But what we see here is a staring look, which is just a sign of sympathetic overactivity. She's not on any medications. She's got no goiter. She's got a heart rate, which is about 116 per minute. She's got tremors. She's got a report which suggests clearly that she's got primary hyperthyroidism. Her TSH receptor antibodies are positive. We'll discuss this patient in a while. But again, as physicians, what we need to really discuss when we manage such patients is some of these questions. And the first question, and since we see that in this patient, the symptoms have probably started even before pregnancy. And if this patient came to us maybe a month before pregnancy saying that, doctor, I'm planning to get pregnant, but these are the reports and I've got hyperthyroidism, how do we manage that? And this is the same paper that I did show. This is the Finnish study wherein we look at the prevalence of using of antithyroid drugs. It's much lower than thyroxine use. I mentioned for thyroxine, there is a 5-fold increase over this 13-year period. But for hyperthyroidism, it is much, much less. These are rare disorders. Well, the medical treatment for thyroid disorders before pregnancy is essentially not very different. But yes, we wouldn't really at times go for radioactive iodine. We do know that if there is administration of radioactive iodine before pregnancy, we need to wait for about 6 months before we can actually think of pregnancy again. Especially in those who have high TSH receptor antibodies, the rate of remission may not be great. Yes, we go on for medical management in most cases, unless there is a suspicious thyroid nodule or a large goiter that is warranting surgery. But once these are managed well, the dictum is that the patient should be clinically and biochemically euthyroid. We should have controlled hyperthyroidism before we give a green signal for patient to go for pregnancy. Talking about the common causes of thyrotoxicosis during pregnancy, a whole list is listed here. Yes, Graves' disease is seen in about 0.4 to 1%, but what is more common in clinical practice is gestational toxicosis. We should know how to differentiate that with Graves' disease and talk about that in a minute. But also sometimes it's patients with oral thyroxine that may be taking paranoidally much more higher doses. That is something also that we need to keep in mind. We're talking about gestational transient thyrotoxicosis. I did mention about the mechanism, how HCG can act on the TSH receptor and produce hyperthyroidism. These patients often present with hyperemesis gravidarum, more common with multiple gestations at times can be because of the mole, or choriocarcinoma. These patients usually have markedly high HCG levels, but clinically, as clinicians, if you have to differentiate Graves' disease from this, we know that if there is no previous history of thyroid disease, there is no orbitopathy, and if it's a mild disorder and there are symptoms of emesis, we think of this gestational transient thyrotoxicosis, and it's important because many times this is self-limiting. Talking about the clinical evaluation and investigations in a patient with toxicosis, it does need to be controlled for several reasons. Yes, several maternal and fetal outcomes need to be looked into, because if there is mismanagement or if there is uncontrolled thyrotoxicosis, it can cause significant problems during pregnancy. We do evaluate these patients. However, we must remember that TSH can be suppressed, and for me to diagnose primary hyperthyroidism in pregnancy, it's important not only to have a suppressed TSH, but also an elevated T4. The TSH receptor antibody is a good test. It can tell me the etiology if it is Graves' disease or not. Ultrasound of the thyroid is only required. Nodules are present, but overall, obviously, we know we will not do radionuclide scintigraphy during pregnancy. And sometimes the T4 and T3 values help us differentiate between thyroiditis and Graves' disease. Talking about management, the key principles, yes, thionides are the mainstay of treatment. And in those with mild disease, we know that at early stages of pregnancy, the autoimmunity can decrease. These are the important pointers that tell us how much of medicine is required, whether I can stop medicine, what should be the average dose. So if there is somebody who's got a long-standing disease on a very small dose, somebody who's got a small goiter, somebody who's got recent TFTs which are only mildly elevated, small elevations in TRAb values, I would not hesitate to probably withhold these medicines given that they have side effects. But if not, and if they are required, what is recommended in the first trimester is propylthiouracil because of the relatively less side effects or the teratogenic effects that are described. But in second and third trimester, we can comfortably use methimazole as well. Most of these are well tolerated. The common side effects, as in non-pregnant states, are more commonly urticaria. Yes, the teratogenic side effects are rare, but we have to be aware. What is also important to remember is that when we treat hyperthyroidism in pregnancy, we have to almost always undertreat. We must know that it is this drug that is not only acting on the mother's thyroid, but even on the fetal thyroid. And it's a much higher dose for the fetus. So they are more effective for the fetus and can cause hypothyroidism in the fetus, even if mother has become euthyroid on treatment. So we undertreat. We don't really push towards low normal T4 values. We keep them high normal. For our patient here, yes, she had frank hyperthyroidism, which was first time diagnosed during pregnancy. She warranted treatment. We did start her on propylthiouracil. She's in first trimester, and she was well controlled after that. The key learning points from this patient have been that, yes, thyrotoxicosis is much less common than hypothyroidism. We must be able to clinically pick up gestational transient thyrotoxicosis. Medical management is preferred as the most preferred modality of treatment for these patients, and it's always under treatment rather than over treatment. So with this, I come to an end of my talk in summarizing the key learning points. From the patient of hypothyroidism, I mentioned about the lower TSH and high T4 physiological changes in pregnancy. We talked about the low value of TSH that is required before clearance for ART and more frequent monitoring required for those who have TPO positive status. For thyroid nodules, we learned that nodules are common, but malignancy is rare. The general rule is wait and watch for PTC, but probably operate if there is MTC or more aggressive disease. And in hyperthyroidism, it's important to differentiate the transient toxicosis. Medical management remains the key. And again, under treatment is better than over treatment. I'd like to stop here, but would be happy to take questions. Thank you so much.
Thank you, Professor Nitin, for that extremely lucid talk, which has covered all aspects of thyroid disease and pregnancy, and pretty impressed with the way you have done it. I'm certain that most obstetricians would remember what you have said for posterity. I would like to perhaps just say a few key points over here before we go further onto the question box. I think Nitin has highlighted the fact of the importance of having a good total T4 and TSH assay, and the important magic cutoff point of TSH in pregnancy of 2.5, and the importance of therefore targeting levels, being a little more aggressive in treatment in patients where you're considering assisted reproductive therapy. The other important fact is that in most situations, when you have a thyroid nodule in pregnancy, you don't need to panic. The importance of certain malignancies like medullary or anaplastic thyroid cancer, which are extremely uncommon, particularly in the scenario of pregnancy, are the only ones where you really need to be worried about and aggressively treat. And the fact that when you have patients with hyperthyroidism in pregnancy, you need to go slow on the accelerator when you treat them, and you do not need to treat them aggressively unless you have the occasional patient who has more severe disease. With that, we'll move on to the question box if there are any questions at this point of time. Over to you, Sean.
Just a couple of questions, sir. So the first question is, if the TSH is in the normal range, that is from 2.5 to 4, and TPO is negative, and we decide as to no treatment, should we follow up or should we repeat TSH, or can we assure the patient that no further test is required?
Nitin, would you like to bat that question?
Thank you, sir, and a really good question. I would, as Dr. Nihal also mentioned, we tend to over-treat here. So I'm not going to start treatment right away, but it's good to follow up. There's no harm. As has been shown in different studies, the TSH values do vary a lot during pregnancy, even if we don't change the medications or we just follow up. So I would probably follow up this patient maybe at 6 to 8 weeks, repeat a TSH and see how things are.
Just to add to the fact that we are looking at a half-life of thyroxine, which is generally about 5 half-lives, that is 5 into 7, 35 days. And so I think the 6 weeks is really the time when you would like to recheck, so around 40 days or so.
Is there any preference to the type of beta blocker that you will use in pregnancy? Is there any variation in that?
Right. So what the guidelines mention is very clear that since the beta blockers are used only for 4 to 6 weeks, most of them are safe. We use propranolol in our practice, but it's often a short duration. And when we use antithyroid drugs, usually the sympathetic symptoms are very well controlled by 4 to 6 weeks. So I don't need to use it much longer. Need not worry about the side effects. But sir, from your experience, any other point?
Yeah. So when you use beta blockers in pregnancy, you are concerned perhaps more in the first trimester and the last trimester in terms of reduction of fetal blood flow. And therefore, you tend to be a little more conservative in utilization of beta blockers during pregnancy. Fortunately, in most situations, hyperthyroidism in pregnancy is mild, and therefore the doses that you need to give are low. So it's looking at the risk benefit. If you do need to give it in the first or the second trimester, try and manage the lowest possible dose. In the second trimester, you can be a little more liberal with beta blockade therapy.
Okay.
So thank you once again for that good talk, Nitin, and we would like to offer a word of appreciation since the applause may not be audible over the internet. Thank you once again, and over to you, Dr. Deepak, for the moderation.
Thank you, Nihal. Thank you, Nitin. And we'll go on to the next session. We're changing gears. We're changing gears to do 2 panel discussions, and this will be very practical. And we are bringing in experts from each of our areas of endocrine surgery, endocrinology, nuclear medicine, radiology, medical oncology, and radiation oncology. So for the first case, which is a locally advanced thyroid cancer, we have Verghese Thomas, who's our assistant professor in the Department of Endocrine Surgery, who will present the case. And may I welcome MJ Paul, my colleague and head of Department of Endocrine Surgery, Felix from endocrinology, Julie from nuclear medicine, Anjana from medical oncology, Ritu from radiology, and Rajesh from radiation oncology. If you could come and seat yourselves here, and we will then go on to the case presentation, which we hope to finish in about 45 minutes. Felix, yeah, all here. Okay, over to you, Verghese. You could start your.
Good evening, everyone. I'll be starting off with the case that we managed in CMC here. So it is a case of locally advanced thyroid cancer. A patient who came to us in 2017. This is a 51-year-old lady from the foothills of the Himalayas. She had a goiter of around 20 years duration, with the size increasing gradually in the last 8 years. She had a new onset swelling over the sternum in the last 3 months. She also complained of pain along the left arm, rising from the neck and radiating towards the arm, as well as she had dyspnea on lying down. She had altered voice quality. On examination, she had stridor on deep inspiration. She had a large goiter, dilated vessels in the presternal area and over the thyroid. There is a swelling around 5 to 7 centimeters over the sternum, which was bony hard. Also, at this point, what would be your diagnosis?
Yeah, so this patient had a large goiter with possible bony metastasis. I think I have mentioned, but it was probably pulsatile, if I remember. So the issue here is what kind of cancer is this? There are different types in the way it presents. One common feature we have to remember is large mass, which has a history of rapid growth over the last 2 to 3 months of doubling in size. Then we must consider an aggressive tumor like anaplastic or lymphoma. This one has a long history of pre-existing goiter, 20 years, and then a noticeable growth over 8 years, and then presented with a metastasis in the sternum. So more likely to be a well-differentiated follicular origin tumor, and would be possibly a follicular or a follicular variant of papillary cancer.
The MPL scopy showed left vocal cord palsy.
So here the issue is also the stridor that she was having. With the large size and the cord palsy, there would be significant embarrassment to the airway and therefore can present as stridor. So this is an urgent case to be dealt with.
Coming to the pre-op assessment, the TSH was 0.023, FT4 was 4.4, T4 was 0.62, and the T3 was high, it was 285. We also did a serum thyroglobulin that was around 1,49,000. So how would you like to interpret the thyroid function, Dr. Felix?
Yeah, in this particular patient, if you look at the history, this lady is from the foothills of Himalayas, and we all know that the iodinization program is there for the last 30 years. And you can see that iodinization problem was predominantly endemic goiter in the foothills of Himalayas. This was work done by Dr. Ramalingaswamy in the way back in the mid 20th century, and he found that the iodine was present in the top layer of the soil. So when there is repeated rain, the iodine washes off from the soil, and there is increased risk of endemic goiter. So that's actually boils down to the point of iodinization program last 30 years. And this lady being a 51-year-old lady and having a goiter for more than 20 years. And this is an endemic goiter and being from the endemic goiter area. So we expect that will be iodine conservation in the thyroid. So there is a deviation of thyroid function from T4 to T3. T4 is nothing but a tetraiodine iodine molecule, that is 4 iodine being present, and T3 being a triiodine. So that is with conservation of iodine, which physiologically happens, and that's why you can see that T4 is low and T3 is high, and TSH is suppressed because of the feedback mechanism. So in other words, it's actually the thyroid gland is running on T3 rather than T4, and T4 is an active molecule, and the feedback mechanism suppresses the TSH. So it's a classical T3 toxicosis. And if we don't look at this properly, somebody may diagnose the patient as having a central hypothyroidism, which we can see the TSH is suppressed, T4 is low, and FT4 is low. So endemic area with the goiter, a T3 toxicosis has to be suspected in as the first place rather than central hypothyroidism. Obviously, this patient will have a high pulse rate and ECG showing a tachycardia. This is a molecule wherein you can see that there are 4 iodine molecule in T4 and 3 iodine molecule in T3. This is a physiological conservation of iodine happens in the endemic goiter. This is a feedback mechanism of which has already been discussed in detail in the previous session.
Dr. Ritu, at this juncture, what all imaging modalities do you prefer?
So initially we'll do an ultrasound of the neck to characterize the thyroid nodule, whether we are seeing benign features or malignant features, depending on what we see on the ultrasound. CT of the neck and thorax is usually done to assess for the extension of disease and the involvement of adjacent structures. The MRI, usually we don't do with thyroid malignancy unless there is spinal involvement and we want to see any compression on the cord.
So looking at these images, what all inferences could you derive?
So this is a chest X-ray, and we can see on the superior aspect of the chest X-ray, there is a large soft tissue density mass that is seen, which is protruding and is causing diffuse luminal narrowing of the trachea, mild displacement to the right. So on this CT section, we can see a large heterogeneously enhancing mass with areas of necrosis and calcification. This mass is extending posterior to the trachea, narrowing it and elevating it. It is displacing the carotid and IJV laterally, more on the left side, and we are not seeing the esophagus separately. So it looks like a large malignant mass. This is the MRI. On the MRI, we can see that the above lesion is the thyroid lesion, and the one that's seen inferiorly is the sternal metastasis. We can also see that the patient has spinal metastasis posteriorly, and we would look for evidence of cord compression.
Also, at this juncture, what would be your plan of management for this patient?
So this case provides many challenges. Fortunately, if it's a well-differentiated tumor, as this appears to be, aggressive surgery can actually provide prolonged palliation, even if we can't get cure. And that is the basic strategy we follow. Now, here there's spinal metastasis. I think was not clear in the imaging, but she had a large met in C6. So we had a combined approach with the neurosurgeons, and it was through discussion we decided we will probably split it into two approaches. First, we did the anterior approach as the first procedure, where excision of the large thyroid mass with excision of the sternal metastasis, which is adjacent to it, and the anterior approach to the cervical spine. We kept tracheostomy backup if we needed, and went ahead and removed it. Now, intraoperatively, the left cord, which was palsied, we expected the nerve to be infiltrated, but it's not. It was stretched by the tumor. So the nerves were preserved, and we completed the anterior approach and gave her postoperative ventilation to see whether we could extubate her successfully postoperatively. There's a picture of the recurrent nerve which was stretched by the large left lobe. This is a picture of the completed procedure, including thyroidectomy and sternal mass excision.
Post-procedure, the tracheostomy was deferred because there was a risk of mediastinal infection because of the sternectomy. She was intubated and was in the ICU. Then post-operatively, extubation failed. Suspected nerve injury during, either of the procedures of endocrine, thoracic, or neuro. Further to that, tracheostomy was done. There was difficulty in maintaining the airway, possibly tracheomalacia of the thoracic level trachea. The second procedure was done a few weeks later. Posterior cervical elements also appeared diseased and were removed, but the fixation in the anterior aspect was deemed to be adequate and no posterior fixation done. Heart collar support was advised for 6 months.
So just to intervene here, this was a very rare case where after we went in for the second procedure of tracheostomy, on putting in the regular tracheostomy tube, the anesthetist couldn't actually maintain the airway. For some reason, they couldn't ventilate the patient. And we were nonplussed for a while, because even though it looked like there would be tracheomalacia with this long-standing compression, usually a tracheostomy solves that. But even with a tracheostomy tube, they were not able to ventilate. And putting in a bronchoscope, they discovered that the intrathoracic trachea was actually tracheomalacic, which is a very rare event. So the trachea was collapsing below the level of the standard tracheostomy tube. So we used an endotracheal tube through the neck tracheostomy opening so that the tip could be placed at the bronchial bifurcation. And only with that we were able to ventilate this patient. Subsequently, the patient was changed to a special long tube tracheostomy tube, which is used in some situations, and thereby she was managed.
The histopathology was reported as Hürthle cell carcinoma involving both lobes of the isthmus, both lobes and the isthmus. The tumor size was around 12.6 centimeters with extrathyroidal extension, and there was capsular and vascular invasion. The perithyroidal lymph nodes that were removed were free of tumor. The separately sent sternal mass also had metastatic tumor, so T3N0. Final histopath being metastatic Hürthle cell carcinoma with C6, C7 vertebral body and spinal process involvement. Postoperatively, this is a picture showing the patient in the ward. You can make out the tracheostomy tube and the heart column. This patient needed adjuvant treatment, so external beam radiation to the spine was planned and a 10-day short course was delivered. Radioiodine ablation of the bone and lung metastasis was planned and followed by TSH suppressive therapy and on follow-up. Over to Dr. Rajesh. What would be the role of RT in thyroid cancer?
Yeah, when you are planning for radiotherapy in thyroid cancer, actually it's with a clear-cut discussion with the operating surgeon. That's what I mentioned in this slide. So we'll have a detailed discussion in the multidisciplinary tumor board regarding the volume of residual disease which was left behind during the surgery, or if the histopathology is showing any high-risk pictures like a polydifferentiated or anaplastic changes, definitely there will be a role for adjuvant radiotherapy. And like this patient, whenever patient is having a spinal metastasis and which is symptomatic, which cannot be completely removed or completely tackled by the surgical intervention, we'll consider palliative RT. Very limited role nowadays in the case of anaplastic carcinomas, like those who are fit patients without any major airway or upper GI involvement, and the family as well as the patient understanding the outcomes. We are doing nowadays our neoadjuvant chemo RT in anaplastic carcinomas also. The very important other thing just want to highlight, now we have conformal RT techniques, so the late toxicities which used to happen in earlier days like cricopharyngeal strictures and tracheomalacia, tracheal stenosis is not happening. So these are the indications for role of radiotherapy in thyroid cancers now. Yeah.
The patient underwent whole body iodine scan. You can see the sequential drop in thyroglobulin. It started off at 1,49,000 prior to surgery and followed by values of 2,654 and down to as much as 28.4 by October 2018. That is one year after surgery. Dr. Julie, how would you interpret the iodine scan images?
As we all know, radioiodine plays a very important role post-op in patients with differentiated thyroid cancer. So the first scan that you see, it's a whole body iodine scan imaging, which has been done after preparation of the patient with low iodine diet, and patient should be off thyroxine for at least 4 weeks. And if patient cannot be off thyroxine, we can also offer recombinant thyroxine injection, thyrogen injections. And if T3 is available, T3 can be off for 2 weeks. And iodine 131 was given orally, which is a dose of 2 millicurie, and we do the scan after 48 hours. So in this image, you can see that there is significant residual in the thyroid bed, and immediate post-therapy, you can also see there has been additional lesion in the right lobe of the patient. So the the residual has been much more bulkier in the post-therapy scan, which is usually done about 5 to 7 days after giving high-dose therapy. And this patient's follow-up exactly 1 year later, you can see the significant reduction in the intensity and in the volume of the thyroid residual. And there is, we cannot see the lung lesions, which is correlating with the thyroglobulin, which has decreased significantly. And I understand that this patient has been lost to follow-up, so we could not have a
Dr. Anchana, what would be the role of systemic therapy in differentiated thyroid cancer?
I think traditionally the role of systemic therapy in TTC would be in the setting where there is RAI refracted differentiated thyroid cancer. And in terms of what systemic, so we have certain criteria wherein we would define what a RAI refractory disease is. And in terms of what exactly the systemic therapy is, we all traditionally know that that TKIs work, and we all know about 2 TKIs called sorafenib and lenvatinib. Now, sorafenib, I think we have data in the TKI naive space, and this was used earlier. Both of these were placebo-controlled trials. Now, what is new is that, again, we all have heard a lot about RET, the role of RET in NT, medullary carcinoma thyroid, where the likelihood of finding a MET mutation is 50%, as 50% in a sporadic MTC. But what is more interesting is that even in papillary carcinoma of the thyroid, around 20% or 1/5 of patients can have a RET mutation. Now, the incidence of this RET mutation is probably lower in the RAI refractory space, that is in the post-treated space. It probably is lower than the 20%, but this is relevant now because of two new drugs which are available, selpercatinib and pralsertinib. Now, we don't really have access to selpercatinib right now in India, but in terms of pralsertinib, it is available actually on compassionate access through Roche. The other mutations which are relevant are BRAF. There are so BRAF V600D testing would definitely be warranted because there are drugs which you can target. So we have vemurafenib and we have a combination of dabrafenib and trametinib, which is a MEK inhibitor. And then, of course, you have some data for things like selumetinib, wherein you are trying to restore the RAI uptake for the tumor. Now, again, more than all these drugs, I think for us, I think what Dr. Ashish and I would sort of stress from a medical oncologist perspective is that for all patients with, when it comes to the need for systemic therapy, these mutation testing would definitely help. Because in terms of what you offer, the number of drugs we've gone on from having only lenvatinib and sorafenib to these extra drugs. And now maybe like last week or so, in the post-lenvatinib, post-sorafenib space, there is another TKI which we use called cabozantinib. We often use it in renal cell cancer. That is approved in that first-line TKI space. So drugs are coming up, and I think the role of NGS is to be, and in tertiary centers like ours, I think definitely we should be doing those mutation testings.
This is a picture of the lady who came back after 1 year on follow-up. She looks pretty happy. So the take-home messages would be, in differentiated thyroid cancer with skeletal metastasis or local regional involvement, it requires a multidisciplinary treatment approach. Resection of the bony metastasis should be considered with a curative intent, symptom palliation for facilitating iodine ablation, and the treatment has to be individualized. So not one treatment fits all. Thank you.
Thank you, Varghese, and thank you to all the panelists who contributed to this. We just wanted to highlight a few things through this particular patient, is that in locally advanced or in metastatic, we need to really go into a proper preoperative planning before we make a call, and also to have multiple players like specialists from various areas like the neurosurgery team who was involved. And it was a really challenging case to manage, especially in the intra-op setting where you couldn't ventilate. And I knew that the anesthetists also were on their toes managing this patient. Took a few days in ICU before we actually got a long tracheostomy tube which could overcome the collapsing trachea, which was low down, below the level of a normal tracheostomy tube. The other thing which came about here was the fact that Hürthle cell carcinoma is usually known to be radio-resistant. And here it was taking up so well. And a 1,47,000 TG came down to 2 digits, which is phenomenal to note that we were able to actually treat this patient so well. Actually, we lost this patient primarily due to the lockdown. She couldn't come back. She comes from West Bengal, from the Darjeeling side, but actually she's a Nepali who lives in India, and she couldn't get back here because of the issues with the pandemic. And I think what stood out was the fact that a good preoperative planning, a good multidisciplinary approach, getting specialists involved, and to go quite aggressively behind these cancers. Whereas as opposed to a well-differentiated cancer, where actually staging happens post-operatively, here you've gone preoperatively and imaged extensively before you've operated and planned it with skills, with specialists from other areas to get a good result. And I must thank you all for this learning. Any points for you from your side, Nihal?
Yeah, thank you. I mean, it's an amazing case which covered perhaps a natural history of almost 3 to 4 decades, and the evolution from an iodine deficient state. I think it was also highlighted of the interpretation of the thyroid function test. When you see this peculiar situation where the T3 is elevated and the TSH is suppressed, one of the conditions you should think of is certainly iodine deficiency dependent goiter, or perhaps what may be even more common nowadays is patients who have toxic adenoma, which may be of inherited origin, wherein one could have isolated T3 toxicosis. So these are the situations wherein one sees T3 toxicosis more commonly. And also the preoperative preparation of such patients, if you have mild disease, you really needn't worry. You need to get the heart rate down with adequate beta blockade, which is more important than treating the thyrotoxicosis per se in the initial phase, unless it's more severe thyrotoxicosis where you need more antithyroid medications. So this particular situation wherein therefore you have moved into a malignant state from a initially benign iodine deficient goiter is highlighted. One of the other things which I would like to highlight is this surgical technique which has been done by the endocrine surgeons, which is so specialized, wherein subsequent residual damage in the neck has been avoided. You haven't had injury to the recurrent laryngeal nerve. Your parathyroids have been preserved pretty well. And largely in previous eras, when we had large goiters, invariably the highly significant prevalence of hypocalcemia which occurred and which needed therefore lifelong therapy. This has not happened. And it shows the importance therefore that multidisciplinary therapy and the treatment of specialists in involvement of difficult goiters is extremely important. Thank you once again, team, for your wonderful involvement and discussion from all specialties across the board and the management perspective. Thank you.
Thank you. Thank you again to all the panelists, to Paul, Felix, to Julie, to, oh, there are some questions, sorry.
Preoperative thyroglobulin levels, does it have estimates, does it have any values?
Yeah, so that's a moot point for a long time. I think the general consensus is now it's not useful from a diagnostic perspective. It's important to remember that some benign conditions can raise thyroglobulin levels. There are reports of benign lesions going up to the range of 600 to 700 in thyroglobulin, and between 50 to around 200, it has very little differentiating capacity where most of the levels lie. So for that purpose, generally it has not been used. I have rarely used it in certain, clinical situations where patients want to follow up and they are atypical nodules, and you just want to make sure that they're not sitting on a small cancer which has metastasized, which is a common, not uncommon clinical situation. And in some cases, I have used that just to rule out that you're not missing an advanced malignancy. It has also been used when you have metastatic lesions and you're not sure where it's coming from. And then thyroglobulin can tell you that this is from the thyroid, typically for bone metastasis.
One more question. When should we check first thyroglobulin levels after surgery?
After differentiated thyroid cancer, we usually check the thyroglobulin only at the first visit, at the time of the whole body iodine scan. It depends on the strategy that is being followed. Most places, our patients only have access to withdrawal of thyroxine prior to iodine. If you are doing a thyrogen stimulated or recombinant TSH stimulated whole body scan, then of course you can do it earlier, as early as 10 days after surgery. But the standard would be between 1 to 3 months after surgery. And at that time, when the TSH is high, we can check the stimulated thyroglobulin value, which will be useful as the first measure.
Okay, are there any questions on the chat, Sean? Okay, thank you so much, and thank you to all the panelists. Thank you to Rajesh and to Anjana too for finishing on time. And to Ritu, please stay on for the next one too. We'll be having the next panel on medullary thyroid cancer, and I'd asked Nihal to introduce the panel.
So next case on medullary thyroid cancer, and I would like to introduce the presenter, that is Dr. Supriya Sen, who is endocrine surgeon, will be with us. And we have also on the panel all the way from Australia, Dr. Anish Cherian, who is also an endocrine surgeon from our department, currently on a study leave in Melbourne. Professor H.S. Asha, who's from the Department of Endocrinology. Professor Rekha Pai, our molecular pathologist. Professor Julie Hepzibah, the nuclear physician, and Professor Ashish Sin from medical oncology. We also have Professor Ritu John from the Department of Radiology, who has been here with the previous session. So I'll just start with a little anecdote about this interesting disorder, which of course was one of the last thyroid cancers to be reported, a disorder which was histopathologically identified only in the 1960s. And in CMC Velo, it so happened that a particular patient, and I do remember Dr. Arvind and I relate the story, who was operated way back in the 1970s, had radiotherapy and was being told to have an anaplastic carcinoma. And this patient subsequently turned up about 10 to 15 years later, alive and well. And then they went back to the histopathology and they found, indeed, this is medullary thyroid cancer. CMC has a legacy of handling this disorder. And of course, my good friend, Professor Deepak Abraham, has done a PhD in this entire area. And the multidisciplinary therapy has led to a huge experience of handling these patients and two large publications from the first decade of the millennium and the second decade of the millennium. Without much ado, I hand over this presentation to Dr. Supriya Sen.
Good afternoon all. I will start the presentation. A 44-year-old female, she presented with paroxysmal palpitations, sweating and headache for 5 years. She also gave history of bilateral flank pain for the same duration of time. She had a left-sided neck swelling, which she had noticed 3 months prior to presentation. And historically, she had undergone a right hemithyroidectomy 22 years ago. The histopathology of the right hemithyroidectomy was medullary thyroid carcinoma. She was advised surgery, but she had defaulted. The family history, the mother had goiter, but she was not treated. The eldest sister expired peripartum due to accelerated hypertension. The elder sister expired immediately in perioperative period post-thyroid surgery. Provisional diagnosis, Dr. Asha.
Yeah, so here we have a patient who had hemithyroidectomy for medullary thyroid carcinoma 22 years ago, now comes with a swelling on the other side of the neck, and along with episodic palpitations, headache and diaphoresis, the classic clinical triad of pheochromocytoma. So we are dealing with a patient with medullary thyroid carcinoma along with pheochromocytoma, which is the classical clinical presentation of MEN2A syndrome. And also there is a significant family history in that two of her sisters had problems related to hypertensive crisis, either during labor or during a thyroid surgery, during which they had severe problems and one had succumbed. So this is a hereditary MEN2A syndrome in this patient. And what we are seeing here is the classical cutaneous lesion, which is described in MEN2A. This is cutaneous lichen amyloidosis, classically seen in the interscapular region as well as over the extensor aspects of the extremities. These are seen in about 51% of patients with MEN2A. Females more commonly have the lesions than men, and this skin lesion is specifically associated with codon 634 mutations. So this arises because of repeated scratching, pruritus leading to filamentous degeneration of the keratinocytes, leading to deposition of amorphous amyloid-like material at the dermoepidermal junctions and in the upper dermis.
Okay, on examination, she had a pulse rate of 110 per minute. Her blood pressure was 160 by 100 millimeter mercury. A scar of the previous hemithyroidectomy was noticed. The left thyroid had a 2 centimeter hard nodule. There were multiple enlarged central compartment nodes, and the systemic examination was no. Coming on to the investigations, the calcitonin was 1986, the CA was 502, and calcium was 9.1 milligram per deciliter. Dr. Ritu, can you elaborate on the ultrasound images?
So the ultrasound image on top shows a complex solid cystic lesion. The solid component is hypoechoic when compared with the thyroid, and there are foci of calcification with posterior acoustic shadowing. This is the lesion in the left lobe of the thyroid. The lower image shows conglomerate nodes, which has similar morphology to the primary lesion in the thyroid. This also has got multiple foci of calcification. It's a lobulated conglomerate nodal mass, suggestive of malignant etiology.
Thank you. What imaging is advised in medullary thyroid carcinoma? Can I ask Dr. Anish?
Hi, just to confirm that you can hear me.
Yeah.
Yeah.
Okay, nice to see and hear familiar faces after a long time. Now, regarding the imaging modalities for a patient with medullary thyroid cancers, I think there are multiple modalities and each have a particular indication. In a patient with a confirmed diagnosis of medullary thyroid cancer, the first imaging modality would be an ultrasound of the neck, and this would be to characterize the thyroid nodule as well as to look for significant or the presence of significant cervical lymph nodes. Now, if you look at our patient, an additional information that we can get is the presence of any residual disease in the thyroid bed that has been operated. Also, I think on the clinical examination for our patient, there was only central compartment nodes and no lateral compartment that were palpable. So an ultrasound would help to further characterize if there were any suspicious nodes in the lateral compartment. Now, secondly, we know that medullary thyroid cancers have a propensity for mediastinal lymph node metastasis. And this is usually seen in patients with extensive nodal burden in the neck. So therefore, patients with extensive nodal burden in the neck, it would be prudent to do a CT thorax, neck and thorax, to look for mediastinal lymphadenopathy. In addition, the CT neck would also help us to plan surgically if there is tracheal infiltration or carotid sheath infiltration or a prevertebral fascia infiltration when there is bulky disease in the neck. Now, lastly, we would also want to evaluate for the presence of metastatic disease. So any patient in whom there is a risk or significant risk for metastatic disease would warrant a CT thorax to look for lung metastasis, CT abdomen or an MRI abdomen to evaluate for liver metastasis. Now, these patients would include those with extensive neck disease, with signs or symptoms of regional or distant metastasis, or those with a calcitonin more than 500 picograms per ml.
Thank you. How would you like to proceed further, Dr. Ashi?
Yeah. So this patient has presented with the classical features of MEN2A syndrome. We discussed about the calcitonin levels and the imaging of the neck as well as evaluation for metastasis from the MTC. So the patient also had the classical triad of pheochromocytoma in the form of palpitations, headache, and diaphoresis, had tachycardia and high blood pressure, indicating that this patient also has pheochromocytoma. And the biochemical evaluation of pheochromocytoma today is to check for urinary or plasma metanephrines and normetanephrines. So as you can see here, this patient had elevated 24-hour urinary metanephrines, and the normetanephrines were just borderline elevated. This is again a classical feature of the RET mutation associated pheochromocytomas, which are predominantly epinephrine secreting pheochromocytomas. So when we look at the various biochemical tests for pheo, we have the assays which have evolved over the years from measurements of VMA to now we have measurement of urinary and plasma fractionated metanephrines. And the best assay is the LCMS, that is the liquid chromatography mass spectrometry, which has a sensitivity of 94% and a specificity of 93%. The immunoassays, which are widely available in labs across the country, do not perform
so well, but they also have very good sensitivity and specificity, more than 90%. When it comes to measurement of plasma metanephrines and normetanephrines, it should be done after an overnight fast with the patient lying supine for at least 30 minutes, and then the sample should be withdrawn. If you take a random sample, there is a high degree of false positivity. And urinary fractionated metanephrines, normetanephrines also have a good sensitivity and specificity of more than 90%.
Thank you. Now moving on to Dr. Rekha, RET testing. About the RET testing, can you just elaborate?
By now, there's already a lot been discussed about the possible mutation in this particular patient. As indicated, the patient had a RET mutation. A little bit about the RET gene. It's a fairly long gene. It localizes onto the chromosome 10. It has about 21 different exons. Now, why is it important that we know the length of it and a little about the gene? Is because not the entire gene need not be screened in every individual case. Particularly in context of RET, mutations are limited to certain hotspots, and I've highlighted that. The RET gene actually is a RET tyrosine kinase, which is a transmembrane protein. Now, if you can go back to the previous slide. So exons 10 and 11 code for certain parts of the part of the gene, that is exon 10 and 11 codes for the extracellular region. And the rest of them, 13, 14, 15, 16, code for the intracellular region. Now, this is of consequence, and I'll shortly tell you why. Next slide. So a little bit about how we perform this in the laboratory. It's fairly simple. If a small sample of blood is available, which is collected in EDTA, we just need about 20 microliters. We extract the DNA. And usually, most labs use a Sanger-based sequencing. There are specific primers. In our case, we use exon 8, 10, 11, 13, 14, and 16. There are 7 what we call as high-risk exons, which are actually checked. But with the advent of NGS, a good number of labs are now beginning to have a paneled approach where RET is one of the genes that they check along with a whole load of other genes. Next slide. In this particular patient, as Dr. Asha had described, there is a C634R. This is C634 is a fairly common mutation. As you can see in the panel which carries the mutation and in the wild type, there is a big difference between, and you can figure the point mutation using this electropherogram. Next slide. And who would we offer this testing system to? Once there is a case of medullary thyroid carcinoma, it is absolutely essential that we check at least for the exons that I listed. And it would also be good to offer the test if the index case is found to be positive to at least the first degree relatives of these individuals. Next slide. It's fairly important, like I said at the start, to know what mutation that this individual carries. As per the revised ATA guidelines, which were released in 2015, it's important to know because each is associated with a certain degree of risk. Like, for example, 918 is always seen in men 2B and is associated with the highest level of risk. 634 and 833 are the next in context of risk, and the rest are associated with moderate risk. This is of big importance to the treating surgeon and the treating physician, because then they get an idea of how likely the disease might progress.
Thank you, ma'am. The patient's son tested negative for RET. However, the nephew was tested positive for 634 mutation, and he presented 1 year later to us with bilateral pheochromocytoma and a medullary thyroid cancer. Now, Dr. Anish, can you elaborate on the timing of thyroid surgery in hereditary MTC?
Yeah, I think ETA has beautifully elaborated on the application of prophylactic surgery in hereditary cancers. And that's why I just put up this slide. This is taken from the ETA. So prophylactic surgery is most applicable for patients with hereditary cancer syndromes and ideally should meet the following criteria. The genetic mutation causing the malignancy is characterized by complete or near complete penetrance, which is seen in MTC. There is a highly reliable test for detecting the mutation, and we have that in the form of RET for hereditary MTC. The organ at risk is expendable, though thyroid is not an expendable organ. It says that if it is not expendable, there is therapy to replace the function of the organ, and we have that in the form of levothyroxine. The precancerous organ can be removed with minimal morbidity and virtually no mortality. And in the hands of a specialist, I think that is possible. And there is a reliable test to determine if the operation has been curative. And we have a good tumor marker in the form of calcitonin. So many hereditary cancer syndromes meet some, but not all of these criteria, whereas MEN2A and MEN2B meet each one of them. And that is the beauty of hereditary medullary thyroid cancers. Now, regarding to the timing of the operation, in patients with hereditary MTC, we know that there is a classic progression from C-cell hyperplasia to medullary thyroid cancer to locoregional lymph node metastasis and then to distant metastasis. And this could be anywhere from months to years, and it would largely depend on the RET mutated. So therefore, in this setting, it is possible to remove the thyroid before MTC develops or with MTC confined to the thyroid. And therefore, the timing is basically based on which RET mutation is present and on the calcitonin level. Could I have the next slide, please? Yeah. So in regard to the categories or risk stratification, as Dr. Rekha had previously alluded to, we know that patients with 918 mutation can present with MTC with neck node metastasis as early as the first month of life. And therefore, prophylactic thyroid surgery for children with 918 mutation is advised within the first year of life, and if possible, in the first month of life. The second category, the high risk, where you have 634 and 883, we know that children with these mutations can develop MTC in the first years of life. It is recommended to screen these patients with an annual physical check, an ultrasound of the neck, as well as calcitonin level from the age of 3, and prophylactic surgery is recommended at 5 years or earlier based on the calcitonin level. Now we know that there is a higher risk of hypoparathyroidism following thyroidectomy in children, and that has to be balanced with the risk of developing medullary thyroid cancer. So in the high risk category, we sort of have to balance that risk versus benefit. And therefore we try and delay it a little further depending on the calcitonin level. In the last category, that is the moderate group, there is great heterogeneity with regards to the aggressive behavior of the MTC and the age of onset. Usually they are less aggressive and they present a little later in life. And therefore, the timing of prophylactic thyroidectomy is based on calcitonin levels in this group. And screening is recommended from the age of 5 years onwards with annual calcitonin level check, a physical examination, as well as an ultrasound of the neck. And thyroidectomy would be recommended based on the calcitonin level. Thanks.
Now moving on to the CT abdomen, Dr. Neeta, can you elaborate?
So these are CT axial sections of the abdomen. You see, this is the arterial face of the CT, and we can see that there are tiny hypervascular foci which are suggestive of metastasis. Sometimes they can be very subtle, and they can be sometimes mistaken for calcified granulomas. This is the other face of the CT, the venous face, showing well-defined lesions in both suprarenal locations suggestive of pheochromocytomas.
Now moving on to Dr. Julie, the indication for MIBG scan in preoperative setup.
In this setup, there is MIBG scan preoperatively for MTC is not indicated. However, we are dealing with a patient with M2A. So we are also looking at possibility of pheochromocytoma. So we know MIBG is an analog of norepinephrine. MIBG is meta-iodobenzyl guanidine, which is tagged with iodine 131. And this MIBG primarily accumulates in the primary lesion and the metastatic lesion. When there is an intact gland, then we may have something called as tumor sink effect, which means we will not be able to identify the metastatic lesion because all the iodine MIBG will be concentrating on the primary lesion. So the role of MIBG in pre-op is minuscule or minimal. It is best performed post-op, and there's just 30 to 40% may be positive on MIBG scan, which is given as an IV injection, 0.5 to 1 millicurie, and the images are performed at 24, 48, and 72 hours.
How will you proceed, Dr. Anish?
So we know that this lady has pheochromocytoma, which is bilateral, medullary thyroid cancer with nodal metastasis and a past hemithyroidectomy, and no hyperparathyroidism. So in this situation, I would likely plan to operate on the pheochromocytoma first, and I would refer to our endocrine colleagues for optimization prior to surgery. And this would be followed by addressing the medullary thyroid cancer.
Periop optimization and preparation of the patient for the pheochromocytoma, Dr. Asha, can you?
Yeah. So this patient has a predominantly epinephrine secreting tumor, and so definitely she needs adequate alpha blockade of alpha receptors for at least 7 to 14 days before the patient goes for surgery. When it comes to other pheochromocytomas, which are either non-secretory or those that secrete norepinephrine, there is a definite role for preoperative blockade in all patients, because while handling the tumors, there is a risk of surge in the hormonal levels, and that can overwhelm the receptors. Hence, all these, both the non-secretory as well as the secretory pheos, while the tumor is being handled, can be associated with hypertensive crisis because of their action on the alpha receptors at higher levels, and that is why all of them need alpha blockade. So alpha blockade is started 7 to 14 days preoperatively, and it should be optimized along with adequate fluid intake, at least 3 to 4 liters per day, along with increased salt intake. And adequate alpha blockade has definitely reduced the mortality due to pheochromocytoma perioperatively from as high as 69% to less than 3% these days. Among the alpha blockers, we have phenoxybenzamine, which is the long-acting, irreversible, non-selective blocker. And we have prazosin, doxazosin, which are less expensive, selective alpha-1 blockers with less reflex tachycardia, but not so good blockade as compared to phenoxybenzamine. With regard to dopamine secreting tumors as well as the non-secretory ones, you would use smaller doses of alpha blockade and for shorter duration. How would we assess the adequacy of alpha blockade? Before the patient goes for surgery, we would need a seated blood pressure of at least less than 130 by 80 and a standing blood pressure of more than 90 millimeters of mercury systolic, and also a heart rate less than 80 per minute. The Endocrine Society guidelines recommend that all patients with pheo and paragangliomas should have adequate alpha blockade for at least 7 to 14 days before going for surgery. And before surgery, in the preoperative period, you would start beta blockers to control the heart rate. Of late, there have been various studies looking at the role of calcium channel blockers for rapid blockade before surgery. So there are some studies which had earlier looked at nicardipine as a possible option. In a study comparing patients who received nicardipine versus those who received alpha blockade use was associated with lesser incidence and duration of hypertensive surges intraoperatively, but with more severe in post-operative hypotension. Recently, there has been an RCT from KEM Mumbai where they compared prazosin extended release with amlodipine in 9 and 11 patients respectively, and they assessed the episodes and duration of hypertensive crisis as well as the duration of hemodynamic instability intraoperatively. And what they found was that all the outcomes were higher among patients who received alpha blockade. So in their study, progressively increase the dose of alpha blockade over a period of 9 days to control the blood pressure. Amlodipine starting from 2.5 to 20 milligrams over 6 days. And once the blood pressure was controlled, they added on a beta blocker if the patient had tachycardia. And if the blood pressure was not controlled with either agent, then they added on telmisartan or clonidine to control the blood pressure. And all the outcomes of hemodynamic instability, as well as the intraoperative episodes of hypertension, as well as the duration of hypertension, were longer among the patients who received alpha blockade were as compared to those who received the calcium channel blocker amlodipine, where they had a smoother control of blood pressure intraoperatively. This is a small study in a small number of patients. So hence we need to study larger number of patients before we can adopt this as a regular strategy. Other agents which are useful, we have metyrosine, which is a tyrosine hydroxylase inhibitor. Though it is an important drug that blocks the enzyme tyrosine hydroxylase, which is the rate limiting step in catecholamine synthesis. Used alone, it did not have significant impact on reducing the intraoperative hemodynamic instability, but metyrosine used along with phenoxybenzamine achieved a smoother blood pressure control intraoperatively.
Now moving on to the surgical options available, Dr. Anish.
Yeah, so there are, for adrenal surgery, there are basically two approaches. One is the open approach and the other is the minimally invasive approach. I think the most common open approach that is performed currently is the open transperitoneal adrenalectomy. With regards to the minimally invasive approach, you have either the transperitoneal laparoscopic approach or the retroperitoneoscopic adrenalectomy, that is the approach from the back. The advantage of doing a retroperitoneoscopic approach compared to a transperitoneal approach is that you don't need to change the position of the patient when you're doing a bilateral surgery. And secondly, if you have two teams, they can do it simultaneously. That's the combined bilateral retroperitoneoscopic approach. It's good to remember that when you're doing a bilateral adrenalectomy, one needs to consider the possibility of cortical sparing operation, where if you can leave about 10 to 15% of normal adrenal, that may prevent a lifelong replacement strategy. But you should also remember that or accept 20% risk of recurrence in about 20 years.
So our patient, she underwent a bilateral retroperitoneoscopic adrenalectomy. Intraoperatively, her highest blood pressure recording was 190 over 110 millimeter mercury, and post-op hypotension, there was hypotension requiring inotropic support. Now the surgical management of medullary thyroid carcinoma, Dr. Anish, the extent of
yeah. So I think the minimal operation for a patient who presents with medullary thyroid cancer and no detectable cervical lymph nodes is a total thyroidectomy with a central compartment neck dissection. Having said that, if you have a patient who has a sporadic MTC and has had a unifocal tumor with no central nodes and has had a thyroidectomy done elsewhere and referred to you, such patients, if they have normal calcitonin level and the opposite lobe has no lesion on the ultrasound, I think it is recommended that we can keep these patients on a follow-up if they're willing to have serial checks of calcitonin and neck ultrasound. Now, with regards to the extent of operation for cervical lymph nodes, I think there are two schools of thought. One is an ultrasound-based approach, where the extent of neck dissection is based on the ultrasound finding. If there is suspicious node seen on the ultrasound on one side, then you would do an ipsilateral neck dissection. And if there are significant nodes bilaterally on the ultrasound, then you would do a bilateral selective neck dissection. The second school of thought is the calcitonin-based approach, where you would perform a neck dissection based on the calcitonin levels, and that is based on what is seen on the table that is presented.
A patient, she underwent a completion thyroidectomy because she had, like I said, a hemithyroidectomy done earlier with a central compartment neck dissection and a bilateral selective neck dissection. In the post-op period, she had a chyle leak. Now to Dr. Anish, how to manage a chyle leak.
So I think the best way of managing a chyle leak is to prevent it. The methods that I follow now is to be careful while dissecting level 4. That is, especially I use the omohyoid belly, the inferior belly of the omohyoid as a marker. You need to have a good understanding of the anatomy and variations of the thoracic duct, and be careful when you dissect below the level of the omohyoid. I usually, for all structures that need to be divided at this area, I usually suture, ligate, and divide. And I find that this has decreased the incidence of chyle leaks and neck dissection. There is, I think there's a great benefit of using energy devices in neck dissection, but I find that there is a higher risk of chyle leaks following the use of energy devices, especially in level 4, probably because we reuse the device and the seal and the cut is not as good as a new device. But if you do detect chyle leak during surgery while dissection, or at Valsalva you identified that there is thoracic duct injury, there are multiple ways of handling the situation. One would be to primarily repair the site of injury. This could be either using a fine 4-0 or 5-0 suture Prolene and suture ligate the duct, usually taking along fascia around it so that the suture is more secure. Or you could use surgical clips to clip the injured duct. In addition, you could use a cover, a myoplasty, using a local muscle flap, either the omohyoid belly or the sternocleidomastoid, and also the use of topical agents such as cyanoacrylate glue, sclerosing agents, and Surgicel have also been advocated. At the end of your repair, it is ideal to place a drain that would adequately drain the region, because even after primary repair, there will be a small amount of fistula that persists. In the scenario where you detect the fistula following surgery, the management would be based on whether it is a low output or a high output fistula. And by definition, low output fistula is drainage of chyle of less than 500 mils per day, whereas a high output if it is more than 500 mils per day. How do you detect a chyle leak in the post-operative period? It could be either clinical or biochemical. Clinical would be if there is a sudden increase in the amount of drain volume, especially once enteral feed has been started. Secondly, if you notice a swelling in the left supraclavicular fossa or erythema at that region, or a fluctuant swelling. And thirdly, classically, white or creamy drain output. Biochemically, if you send the drain fluid for triglyceride level and it is above 100, or if the drain triglyceride level is above the serum triglyceride level, or if you have detected chylomicrons in the drain fluid. So those are usual methods that are used to confirm a chyle leak. Now, if you have a low output fistula, they can generally be managed conservatively, and the aims of management of low output fistula would be, one, to decrease the amount of output, and the methods for these include bed rest, as we know that activity increases output, use of stool softeners, this would decrease intra-abdominal pressure during bowel movements, dietary modifications by initiating either a no-fat diet or a low-fat or a medium-chain triglyceride diet. The use of tranexamic acid has been shown to decrease the volume, especially in low-output fistulas. Octreotide has been described, but cost is a limiting factor. Secondly, would be to manage the wound, ensure that the drain is functioning and there is adequate drainage. If the drain is not working, you could shift to a negative pressure drainage system. You should also ensure to replace fluid and electrolyte losses and maintain and replete the nutritional status. In a high output fistula, it would be prudent to re-explore as early as possible, re-explore the neck and identify the site of the leak or the injury and use the methods mentioned below for repair. The other alternative would be a video-assisted thoracoscopic approach and ligate a thoracic duct in the thorax. Though I have outlined the methods used for management of Kyle leak and a general algorithm, I feel that the treatment should be individualized, as most patients coming to Vellore for treatment are from faraway states with out-of-pocket expenses. And though low output fistulas can be managed conservatively, it may take a couple of days to weeks for spontaneous closure. And staying this long, considerable financial burden for some patients. Therefore, it may be prudent to re-explore the neck early in such patients, even if there is a low output fistula, to aid faster recovery. So in summary, the treatment of Kyle leak should be individualized based on patient factors as well. Thanks.
Okay, patient, these are the serial calcitonin and the CA levels. In April 2016, it was, like I said, preoperatively 1986 and 502. In May 2016, she underwent a bilateral adrenalectomy. In July 2016, she underwent the thyroid surgery. And on her first follow-up, subsequently in September 2016, her calcitonin was 4,760. And in June, it was 7,280 with a CA of 382. Calcitonin doubling time to Dr. Asha.
Yeah. So the ATA has provided an online calculator to calculate calcitonin and CA doubling times. So the reason why this is important is that patients who have rapidly increasing calcitonin levels, that is their calcitonin doubling time is less than 6 months, have a very low progression-free and overall survival. So the survival rates are as low as 27% at 5 years and less than 10% at 10 years. Whereas in comparison to those who have calcitonin doubling time more than 2 years, they are likely to survive for a long period, and their survival is not affected because of the calcitonin, because of the disease.
Sorry to interrupt, you are not audible.
Sorry?
Yeah, now you are audible.
Okay.
So in addition to calcitonin and CA doubling times, use of periodic imaging to assess the tumor volume doubling time in addition to calcitonin or CA would also be helpful. So the calcitonin doubling time is calculated by putting in about 4 values of calcitonin over a period of 2 years or CEA, and the calculator would give you the calcitonin doubling time. In this case, in this patient, the calcitonin doubling time was 9 months from what is calculated from this calculator, and it indicates that she has an aggressive disease. When the calcitonin doubling time is less than 2 years, that is less than 24 months, it is considered as an aggressive and fast spreading tumor.
Now moving on to the management of a metastatic MTC, Dr. Julie.
So when we do the post-op MIBG scan, and if MIBG scan is positive, then we can subject this patient for an MIBG therapy. So how is it administered? We give about 1 to 2 millicurie per kg body weight of iodine 131 MIBG, which is given as a slow IV infusion over 4 hours. that is 25 millicurie per hour. And this is repeated once in 6 months if follow-up MIBG scan is positive. And knowing in metastatic medullary thyroid cancers, MIBG is not positive in the sense it's about 30 to 40%. And if it is positive, we can proceed with the therapy. So in this image, you can see that we have acquired the images over 24, 48, and 72 hours. This is to ensure that there is a progressive washout in the physiological uptake, such as heart and liver, and kidneys and the bladder, and progressive increase in uptake in the primary or the metastatic lesion. So in this image, the scan is a negative scan with physiological uptake even in the thyroid, in the salivary gland. This is because there will be some amount of free iodine 131 which is taken up by the salivary gland and the stomach. So this is another patient where you see that the MIBG scan is positive, and you can see that there's an uptake in the thyroid bed. So this is a positive scan with physiological uptake in both the liver and the bladder. So the other options, I think I can come to the next.
Yeah.
Next slide. Oh, sorry. Should I talk about lutetium?
Yeah, can you just finish?
So the other options that we have for medullary thyroid cancer is you can image the patient with gallium-68 dotatate PET CT, and if this is positive, the patient can be offered lutetium-177 dotatate therapy. And as you can see in this slide, this is a patient who was treated with MIBG because initially the MIBG scan was positive. You can see there's a residual tumor in the thyroid bed, and follow-up, we can very clearly see that the calcitonin was progressively increasing. And this patient came for follow-up after several years, and we subjected him to a gallium dotatate scan where you can see there's extensive disease predominantly spread to the bone. Predominantly it's an osseous lesion, and he had taken lutetium-177 dotatate, and post-therapy scan in the middle, you can see that there is some uptake in the skeletal lesions. However, this patient did not really improve even in spite of the PRRT, that is a peptide receptor radiotherapy that we call the lutetium therapy. And so for lutetium therapy, the pre-therapy workup that we do is a complete blood counts, renal function, and renal scans to ensure that the patient has a good GFR and the tubular functions are good. And the dose that we give is about 2 to 3 millicurie per kg body weight. It's given as an IV infusion over 30 to 45 minutes. And along with it, simultaneously, we give amino acid infusion with arginine and lysine. This is given to prevent renal tubular damage by the peptides. And a minimum of 4 doses are administered once in 2 months.
This is the picture ma'am had just described. Now moving on to the systemic therapy in medullary thyroid cancer, Dr. Ashish.
So when it comes to treating these patients with systemic agents, first thing we need to decide is when do we start therapy? Now, as Dr. Asha very nicely elaborated, a lot of these tumors are very indolent, and they're very tiny, small nodules, few nodules in the lung, liver, which doesn't bother the patient at all. So many times we ask this question that can we just watchfully observe this patient? And both, I think all of us have had patients which we have just observed for many years. And also some people would say that you should take into account the size of the largest metastasis. Anything which is beyond 1 or 2 centimeters tend to become aggressive. And then the doubling time and other things. But when you have a patient who actually is symptomatic and then we need to initiate therapy, there again, I would say it should not be just medical therapy. It should be again a multidisciplinary meeting. And many times even we can use surgical expertise. If it's a solitary large tumor which is causing trouble, we can do resect that, and including radiation and on whatever other DOTA and everything which we just discussed. But when it comes to, if you have multiple lesions which cannot be targeted by local treatment, and so there are actually two major class of drugs we use. One class is the anti-angiogenic multikinase inhibitor. When I say multikinase inhibitors, that these are not specific towards a particular kinase, but they act mainly anti-angiogenic effect than other ones like RET, MET, AXL, PDGFR, and then we actually have the pool of data we have is actually more robust for these drugs because they've been there for some time. And on your screen, you can see the two large randomized trials of these two drugs, vandatanib and cabozantinib. Now, why vandatanib and cabozantinib? Because they do have some RET inhibition as well. Not predominantly RET, but they do have some RET inhibition. And therefore, these manufacturers went ahead and did those trials. And if you see that these drugs don't melt away tumors, like you don't get complete responses, you usually get a stable disease or a partial response. When I say partial response, we use a criteria called RECIST. So by that. And more important than that is they stabilize the disease and these patients can stay on this drug. And if you look at the progression-free survival of 30 months, which is quite a long period of time. And when these patients have to take these drugs for so long, what we usually struggle with is managing the toxicities. Because these are multikinase inhibitors, they usually have problems like mucositis, hypertension, diarrhea, hand-foot syndrome, and sometimes rarely even liver and lung toxicity. So it becomes a challenge and quality of life can actually be sometimes poorer. And patients do interrupt, they be dose reduced, especially with these drugs. Then to overcome these problems, a lot of now people are trying to develop RET specific inhibitors. And because these are new drugs, we don't have these large randomized phase 3 trials. Those are ongoing. But we do have information from these single cohort studies where the response rates are more impressive. Like you see on your screen, if you use selpercatinib in treatment-naive patient, the response rates are at 70%. And the complete responses also are seen maybe about 10%. And the good thing about these drugs are because they're specific, they are better tolerated, and they don't have these anti-angiogenic and other effects, and patients can stay on these drugs for a long time. And currently in India, actually, there is a randomized trial going on where patients are being randomized to either vandatanib, cabozantinib, or selpercatinib, and we look forward to that data. Similarly, there's another drug called pralsetinib, which is again both are from different manufacturers, but they more or less they do the same things. Now, as a clinician, if I have a choice of both of these class of drugs, I would how to sequence. Shall we go for a specific one or the anti-angiogenic one? It's a difficult decision. We'll wait for the results. But sometimes they say that even the kind of mutation may make a difference because if you have this the gatekeeper 804 codon mutation is very sensitive. The pralsetinib is very sensitive. But there's another one called solvent front 810, which is usually resistant. So maybe in future we'll learn more. We'll decide which one first based on the kind of mutations present. And also these drugs access may be difficult in India, but not to forget that even other than vandatanib, cabozantinib, the other available ones like sorafenib, lenvatinib, and even sunitinib, just to inform the audience, cabozantinib now we have generic available just last month, and it costs almost 6,000 to 7,000 a month. So with all these other TKIs, I think we have to use it judiciously. None of these trials have shown an improvement in overall survival, and the reason for that is I think is because these tumors are so indolent. At some point in time, the patient will be on these drugs. So even if we are able to use it later on, there is no harm, and one should decide the sequence carefully. Yeah, I mean, last week I had a patient who was on his 12th year of vandatanib. He's lucky because he's on a clinical trial, he's getting the drug and he's tolerating it quite well. So.
To talk, or shall I just move to the next?
Yeah.
Yeah. Okay. We had a patient who was kept on vandatanib, like Dr. Ashish just mentioned, and these are the CT pictures following the vandatanib. So,
you can see there's decrease in the size of the nodes when compared with the previous ones.
Okay. These are the intra-op features of the surgery done, where he had a total thyroidectomy, central neck dissection, bilateral SLND, and mediastinal lymph node dissection. These are the sequence of his calcitonin and CEA over time. And as you can see, post surgery, he had come down from 46,800 to 1974. After initially pre-op, he was given like a neoadjuvant TKI, then he underwent surgery, and then subsequently his calcitonin had stayed low, and then he was put back on vandatinib, and this year January we have a value which is 1245. So that's all. Any questions?
There are some questions on the chat, but I'll ask Nihal to close.
So thank you for that very comprehensive discussion. I think you've highlighted the fact as a panel, the importance of quaternary care, the importance of multidisciplinary therapy, which is absolutely necessary for a disorder like medullary thyroid cancer. I would perhaps like to highlight the fact, in fact, the way that Dr. Ashish tapered off when he talked about anti-mitotic agents for treating these disease, the tyrosine kinase inhibitors. The important fact in our country is cost. And therefore, when we use these medications, there is a large segment of patients who can afford these treatments for some time, but thereafter may not be able to afford them. And from our clinical experience that the endocrine surgeons, medical oncologists, and the nuclear medicine team, we do realize that how much can we really cure in these patients. Many of these patients have a good quality of life living with the disease. I do agree with the fact that good surgical removal of whatever is possible is there. But even patients who have metastasis can have amazingly good lifestyle for a long time. The emergence of better nuclear imaging techniques like lutetium scans have paradoxically helped in the detection of unseen disease which may have not been seen 10 years ago. And this does not necessarily mean that these patients can have better treatment. Julie has shown you quite clearly that lutetium therapy does not work in a good number of patients as well. And I think that's shown with a very good clinical experience from CMC and India in general. We have used low-grade forms of tyrosine kinase inhibitors like sorafenib as opposed to the standard of treatment, and have had some reasonably good results. Deepak will allude to the eradication of disease in some patients who've had that forms of treatment. So innovation is important. Understanding that patients can go as long as even 2 decades with existing metastasis. We've had patients who've had bone metastasis with paraplegia who have lived for 20 years with the disease. Patients with hepatic metastasis who have lived for 10 years with the disease. So it is an interesting condition. Asha has highlighted the fact of calcitonin doubling time. And if the doubling time of calcitonin is not significant, these patients can do amazingly well over a period of time. And so therefore that psychosocial aspect of giving constant hope in spite of having existing disease is really very, very important in this case. Deepak, you probably would like to say a couple of words, and then we could even go over to the questions as well.
Yeah, I think we must not give up hope. I think that's the most important. And even if you looked in this panel discussion, Ashish came on the last. That's pretty much how TKIs come on. You know, you use TKIs at the last when you have got what I put it as easy to say. Remember, is to painful or progressive, non-resectable metastatic disease is when you bring in TKIs. Otherwise, you don't treat a number, you don't treat calcitonin, you don't treat CA, you treat the patient. And I think that's an important thing to remember. And we have a patient who actually our first experience with TKIs was in 2014 when we started with a post after we gave him pre-op sorafenib. At that time, that was the only thing available in 2014. We gave him 3 months and his calcitonin was in the 40,000 range. 3 months and it all regressed like what we see in that patient. And we finally went on to surgery followed by sorafenib and it's plateaued off. It didn't respond anymore. Then he kept looking for every trial possible in the world. He was on clinicaltrial.gov. And through connects we had through our own links, we actually got him on to Loxo 292, which was basically selpercatinib done through Eli Lilly. And he got the drug and he keeps getting the drug. He just has to go to Singapore to get the drug. And today his calcitonin is in the range of about 110. And he's doing so well. And he's got a normal life. He is 2021. 2021, and he was stage 4 at the start, and today he's doing well. So I think MTC is a very interesting but very challenging, and when we work together, we will really make a difference to them. And especially, I think the offspring and these siblings who can be cured if they've got no tumor seen, but they've got a mutation positive. And that's something more which I'd like to highlight. Sean, any questions?
In medullary thyroid cancer, what is the role of surgery in a metastatic setting?
Okay. Anish, you want to answer that?
Sure. So in a metastatic setting, you know that it is not a curable disease. The role of surgery would be to prevent progression of the disease in the neck that would result in morbidity to the patient. So tracheal infiltration or nerve infiltration could be prevented if it is an operable MTC in the neck. So otherwise, it's not a curable or a curative surgery.
When you have concomitant medullary thyroid cancer and pheochromocytoma and CT is showing lung metastasis, is there any way to differentiate whether the metastasis is from pheo or from the MTC?
Okay, I think Anish, you want to answer that? Okay. I think the point is pheochromocytoma in a M2A setting is not malignant. The MTC is malignant. So if you've got metastasis in an M2A setting, it is from MTC, not from the pheo. The pheo itself is a benign condition.
Margin positive MTC, what is the next step? If you have on histopathology, the margin is showing MTC and that is positive. Is there any role for any other adjuvant therapy because the margin is positive?
Yeah, I think the point is about R0 versus R1 resection or R2 resection. I mean, the first operation is the best operation. And so in the setting of MTC, like in our few patients we've had, there is data gathering to point that there is a role to go neoadjuvant systemic before you operate. So whatever operation you do, even if it's delayed, that should be the best operation. So the aim is to get as good a clearance as possible. In gross R2 residual disease, there may be a role for radiotherapy. And we didn't bring it in because primarily in this patient, we did not use it. But we have used external beam RT in patients with MTC2, especially if we got an R2 resection, and that is painful or symptomatic in the neck.
Which is preferable, ma'am? DOTA-TATE, DOTA-NOC, or DOTA-TOP?
Oh, okay. DOTA-TATE is preferable because it is more specific for somatostatin receptor 2 and 3. And most of the lesions, that is malignant lesions, have somatostatin 2 and 3. And so I would prefer DOTA-TATE. Another thing that I would like to highlight here is there are other PET imaging, radio tracers such as fluorodopa and FDG. Fluorodopa is actually the investigation of choice for medullary thyroid cancer. The reason we don't use it is one, it's not available. The second thing, it does not have a theranostic component. So knowing that this is a extensive disease and unable to treat with a radio tracer, so that is one of the disadvantage of fluorodopa. Dopa is dihydroxyphenylalanine, and so it is better to, when you have a theranostic component, you can image and you can treat. So that is why we do not, first of all, we don't have DOPA, and we would prefer to use a theranostic component when we are imaging.
Okay, I think we've, okay.
Is there any role for iodine therapy in thyroid, in MTC? Because it is for parafollicular cells.
Okay. So initially, the concept of bystander effect was there for radioiodine ablation for MTC, especially in the thyroid bed and not for the metastatic component. But however, this practice is obsolete and it's no longer used.
Okay. Thank you all for this beautiful discussion. Before we close, I'd like to just invite Dr. Arvindan Nair, who's on this meeting. He is the founder, or the senior, the mentor to many of us here. especially to Paul and I, who work in endocrine surgery. And sir, would you like to make some closing comments before we wind up?
Thank you, Deepak, for inviting me to participate in this thyroid masterclass. Thyroid surgery, especially all aspects, have changed dramatically over the years. I'm so happy to see that a multidisciplinary team can handle it so well now compared to our days. And even then, we used to have multidisciplinary, but we didn't have so much of drugs and gadgets as you have now. So it's really interesting to see how we have evolved for the better. And ultimately, the patient is getting the best of what is available in the world. And especially, we are also very cost conscious, which is very important for us. So I think this update is very good, especially in this world when everything is now virtual. I think more people can listen and get the knowledge and benefit from you. Thank you. Thank you very much.
Thank you, sir. Thank you once again to all the panelists for making this a very meaningful discussion. And before we close, we must not forget that we need to thank our sponsors who have been there through this meeting and been instrumental in getting this across. We've got about 2,000 plus people who've registered to this meeting. So thank you once again, and wish you all a good evening. Thank you.
Thank you, sir. Support, please go offline.
Yes, okay.
Support, are we offline?
Anish, are you there? Great. Thanks.
So please tell him he needs a haircut.
I'm here, sir.
Anish?
Yeah.
Hi, thanks so much, Anish. I forgot
no
to
worries, sir.
especially thank you.
No worries, sir. Nice to
Thanks.
see you.
It's quite late for you, right?
It's 11:30, sir.
11:30. Okay.
How are you?
Yeah. I'm good, sir. Thanks.
Yeah.
All good.
How's your wife doing? She enjoying her work there?
She's enjoying herself, sir.
Okay.
It's a nice place and good contacts.
Say hi to Sharon and others over there in Melbourne University.
Will do, sir.
Yeah. Okay. Bye.
Hey man, where did you get all this hair from, man? You didn't have
Sir,
it when you went from here.
No barbers here, sir. Lockdown, so everything is shut.
Okay, great. Okay, anyway, good, nice. It was. I think the Kyle was a bit too much for the audience, I guess. Because it was multidisciplinary. We could have trimmed that down, but otherwise it went well. Okay, thanks. Thanks. Yeah. Okay. Bye bye.
Thanks.
Bye. Good night. Go to bed. Thank you so much.